When seconds matter, coordination saves lives. Across Central Texas, trauma systems, hospitals, and EMS agencies work together with one shared mission: better outcomes for every patient. Welcome to the CATRAC podcast, where leaders connect, systems improve, and regional care moves forward.
Welcome to CATRAC's podcast. I'm Douglas Havron, the CEO here at CATRAC, and we welcome you today. And welcome to Annie Burwell, who is the Mental Health Workgroup Chair here at CATRAC. We really appreciate you being here to kind of talk about the Mental Health Workgroup. Will you kind of give us a little introduction as to who Annie is and your experience, and then we'll kind of dive into the workgroup itself.
All right. So I'm Annie Burwell, and I work with Round Rock Fire Department as the program manager for the crisis response unit. And before that, I was with Williamson County with the mobile outreach team, which was a division of EMS. I've been doing crisis work for about 30 years and am happy to be working with CATRAC on a regional model, or getting the region kind of up to where it needs to be.
Yeah, we're going to dive into those goals here in a second. And so thank you so much for serving in the role as the mental health workgroup chair in the 11 counties that we serve. It's, kind of expansive. So talk a bit about the mental health workgroup goals. What are the goals of that work group?
Sure. We have 3 goals for this year. We have doing a better job at disaster behavioral mental health, which is coming to some sort of practical system around how we want to respond as a region when there are disasters. Who responds, how they respond, is there any criteria for that response? And that would, of course, be in coordination with other state and regional and local agencies. So that's one goal. The second goal is improving peer support and first responder behavioral mental health. So making sure our workforce stays mentally healthy so that they can continue to do this work, which is very difficult and trying. And so that's the second goal. The third goal is the most, maybe the most challenging and the most important in my eyes, and that is bringing the 11 counties together in a efficient and pragmatic approach to pre-hospital care for behavioral health, and making sure everyone knows how we get someone to emergency behavioral health care, whether that's substance use or psychiatric care.
So I really like those goals because it really kind of looks at the vast nature of that work in mental health, whether that be mental health for our own, right, for the staff and the responders, which we really saw as a significant issue in 2025 with floods, and then kind of a repeat of that in July of 2026 with flood response again, another large component. So I really like that kind of peer support in the first and second goal, and then clearly the more public facing goal of streamlining process. Can you talk a bit about that first initiative, that first goal, a little bit more? What are the plans around that?
So we're just kind of getting our toe into talking about what is the best way for jurisdictions to come together when there is a disaster related to things like family assistance centers, death notifications, how these should work, who does them, what are best practices. Are we tasking the local services? Are we sort of double tasking them? So they're having to respond to the disaster itself, and then that second layer of all the stuff that comes immediately after or towards the end of an incident.
Right.
And so how can we bring in other resources from the region to support the area that's most impacted, so that we can make sure that those long-term systems of care stay healthy, because we know that, we're still recovering from the floods in 25 and other incidents and disasters, and we just need to make sure that the whole system supports all the pieces. That's a little bit vague, I
And
think, but
that system you're talking about is the region system
Mhm.
and how it interfaces with the state and the locals, whether that be the Texas Division of Emergency
Mhm.
Management, whether that be Texas Emergency Medical Task Force, whether that be public health, search and
Right,
rescue, all of
right,
those, the
right.
medical examiner or the justice of the peace and all
Yes.
of those pieces. That's amazing. Then the peer support as the second goal is, I know, a big priority for me. It's something that we here at CATRAC have talked to our membership about and had a number of experiences with some of the deployments that we had in 25, particularly I know that there's technology for peer support. There's a new initiative, I believe, even at the Texas Division of Emergency
Yes.
Management related to peer support. Talk about you've done a lot of peer support over the
Mhm.
years. Talk a bit about how important that is. I know that many of our audience members are probably pre-hospital
Mhm.
providers listening to this and know that there is peer support. There is those services available. There's outreach that you can do. But there are also individuals listening to this that may not be aware of what peer support is, particularly peer support in the pre-hospital world. Talk a bit about that and why that's so important.
So we do have a lot of peer support in the region, and what peer support is that if I run a terrible call and I'm having a hard time with it, I can reach out to a peer and say, "Hey, I just need to process this." It's not therapy, it's not even counseling, it's just a way to get some support. Hopefully, that's provided by a peer that's been trained in peer support so that they can say, "Oh, Annie, that's really terrible, and also, I think we need to get you some additional support." So, there's some levels to peer support, just sort of processing and making sure that, I'm okay or you're okay, whether that's one bad call or whether that's an accumulation of many calls, and there's one or two calls that really sort of push me into a place of not being able to function at my best. And
Right.
so we really want to make sure that the peers in our region have some baseline training. And once they have that baseline training, um, does everyone know how to get peer support?
Right.
Now, in larger agencies, that's pretty well established and runs well most of the time. But when we have a major incident where, let's say, 3 or 4 or 5 crews are impacted, probably some of those supporters are also impacted. So again, it's just like disaster behavioral health, like, why are we double tasking
Right.
people?
Right.
So can we say, "Okay, if my jurisdiction's really impacted, can I reach next door or can I reach 3 counties over?"
Yeah. And sometimes that's really obvious when it's a large incident or it's a big scene or it's that really bad catastrophic incident, even if it's a singular patient or
Mhm,
whatnot. But I also think peer support sometimes means when I run that routine normal call that just reminds me of mom
mhm,
or just reminds me of my baby, right? And
mhm,
and while the call may not be significant or the incident may not be newsworthy, if you will, it touches me as a human who's just a regular
mhm.
medic, right? Or a regular nurse or a regular responder. It hits me in a way that's maybe abnormal because it's just so close to home. And we need to support those individuals. And we're
Absolutely.
tough and rough, and a lot of guys don't want to ask for help, and gals don't want to ask for help, and tighten the belt and move on to the next call. But those live with us. I know I have those that live on my shoulder. We all
Oh,
we all
for
do, right?
sure. And what we're really concerned about too is our rural jurisdictions, right? So we want to make sure that they have the same support as someone who
Right.
works in a large agency. So uh, if we know that they've had a bad incident, how do we reach out? And then also, like you're saying, I'm just running a regular call, but for me personally, it's a tipping point or it's an upsetting place. How do I get in touch with someone? And if I'm in a small jurisdiction, I probably don't want to talk to my partner.
Right.
I probably want to talk to someone else. So we're really hopeful with some work that we're doing with TDEM. They're getting ready to launch an app, and instead of both of us sort of working the issue, we're going to work hand in hand.
That's wonderful. That's
So
wonderful. Let's talk about that third goal, the bigger
okay,
the bigger piece of the pie. I think
okay,
it is. And to me, that third goal about the patient experience and the patient workflow for access of mental health is kind of divided into two buckets, if you will. So there's that pre-hospital in the field component,
Mhm.
and then there's those patients that are at a hospital, typically in acute care emergency room.
Mhm.
Maybe they had some medical issues that need to be taken care of, whether that was sutures or detox or,
Mhm.
some hydration, but then have the comorbidity, if you will, of some mental health disease and who need access to mental health care purely after
Mhm.
being medically cleared. So those are the two buckets for me. Let's talk about, I think, what is maybe one of the harder of the two is that pre-hospital environment. Can you, I'll ask the question this way. Can you describe what the standard mental health access to care process is, no matter if I'm in a particular county A or county B or county C? What's the standard? I'm a mental health patient. I need mental health services purely.
Mhm.
Can you write that out in a sentence? What is that?
Heck no. I wish I could. Like that's the exact problem. So instead of having a clear protocol where we would with stroke or STEMI or something like that, where your feet are really determines the type of care, the type of response, how quickly you're going to get that response, what happens with you during that response, where you're transported to, how you're transported, who takes care of you and in what setting and what insurance you have. So it's a huge
Just
algorithm of mess um, driven by a bad combination of freestanding for-profit psychiatric hospitals, which is what we have in this region, uninsured pressures or pressures on the uninsured system that has been sort of tasked to the LMHAs, and then no definition of medical clearance, and then the insertion or um, the need sometimes for law enforcement.
so I want to go back because you mentioned a number of things. I heard, adjective, comma, adjective, comma, adjective, comma, da 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 da. And then I heard it depends on where you are. And then I heard, organizational involvement, etc. And you compared all of those factors to other standards like STEMI, you said, and stroke. And if for those who may not know what that means, we're talking about heart attack patients that have a standard best practice that we all follow across the board, or stroke patients. We have a standard minimum assessment and identified stroke facilities and identified STEMI receiving, cardiac receiving facilities, right, in this region. So we know exactly that patient presents this way, we do these things, and we go to these places, and
Hmm.
this is the standard, right? We
Hmm.
know that for trauma.
Hmm.
Everybody knows that for trauma, right? Even the layman knows how the general trauma
Hmm.
care works. But for mental health, you describe this length of sentences or length of adjectives in your sentence with a number of factors that sounds like I need a supercomputer to figure out
Hmm.
where I'm supposed to go.
Hmm.
Um, that's not best for the patient. We
Oh,
should know
no.
exactly what to
It's
do.
terrible. It's terrible. And part of that is uh, the stigma associated with mental health, behavioral health that we haven't caught up to the rest of the pre-hospital world, right? So there's some feeling of like, well, if they would just
XYZ, yeah.
right? So that's completely unfortunate. The other issue is every jurisdiction wants to do things a little bit differently, and every um, psychiatric hospital has a little bit different definition of who they're willing to accept and when and under what conditions. And so, yeah, it is broken, and it's been, broken for years and
So
years.
that's so. I know it's challenging for you, and it's challenging for the patients. And from a RAC perspective, right? We regional advisory councils are tasked in statute, really in Texas, right? We're just talking about Texas at the moment, is to decrease mortality and morbidity and increase patient outcomes. That's our goal. That's why we're here today talking about this particular cohort, right, of mental health patients. And in order to decrease mortality, morbidity, and increase patient outcomes, we really need to look at the data, and we need to measure our intervention against that data and see that the data trends good or bad, and if it's bad, change that intervention. So we do that with, clot busters in the cardiac wound stroke world, right? We do that with time to the OR in trauma. We do that with, pediatric care and certain time intervals. But I don't see those in mental health.
You see it in pockets.
Okay.
So there are jurisdictions who are really devoted to doing better. But most of the state and most of the region, unfortunately, has a sort of, uh, I guess we could call it like a hurry up and wait model. So if someone calls 911 and says, my brother is has severe mental illness, and he has stopped taking his medication, and he's agitated, and he's hallucinating, who is going to show up?
So to me, I go back to what are those basic standards, right? So we are certainly not here as an advisory council to define protocol, right?
Right.
We are not going to
Mhm.
intervene in physician practice. But there seems to be like this desire or need, I guess, to define what are the 3, 4, 5 basic standards for mental health, right? So to me, maybe I'm making this up, but maybe one of them might be time to call from call
Mhm.
to psychiatric evaluation by a mid-level or physician
Mhm.
practitioner, right? Maybe that's an objective. I don't know. If we had that objective, then we could measure that objective and
Sure.
say, are we getting better? Um, and what I hear is in some, you said depends on where your feet are planted, I believe those
Uh-huh.
were your words. In some jurisdictions, maybe we have that. It would be amazing, I think, and tell me, is the work group working on this? To me, it would be amazing if we could take some of those best practices, just the first 3, the first 9, whatever that number is, and write them down as the CATRAC standard for mental health care in the 11 counties. So we have that with stroke, we have that with trauma, we have that. And in fact, in many cases, the Department of State Health Services requires that we write a plan around those particular cohorts of patients. Whether the department requires us to do it or not for mental health, I think that's what's right. That's what's right for patient care.
Well, sure, it seems very logical, right? It seems very straightforward. But if I go back to that question, you call, and you could call 911, or you could now call 988. Who shows up? Who shows up? So in Round Rock, you're gonna get a different response than you are, I'm just gonna throw, like,
In another
in another
another
county,
city.
another city. Um, so you may get a fire truck because it's an emergency, and it might be medical, and we need someone to get there quickly, right? So you might get, like, a fire engine in front of your house.
And
And
the
then
level of training of that particular paid or volunteer fireman may vary dramatically
greatly,
related to
right?
mental health.
Right. Then you may get an ambulance. You also may get an officer because we have crisis intervention officers, we have mental health officers, we have patrol officers. If the word agitated comes through the PSAP, then the dispatcher's like, agitated officer, right? Like,
Right. It's a safety issue. Let me
right,
send in a cop, right?
right. So you probably get those 3 responders, none of whom are trained in behavioral health, except maybe a 40-hour class or 1 day as part of your paramedic training or
10 years ago.
yeah, right. And so you're asking a group of highly skilled, expensive people and expensive equipment to show up to a sad person. And that's pretty insane, right? So we say, okay, then what do we do? Well, we can't then agree system-wide, like what happens next. Well, do we take this person into custody? Do we transport them to an emergency department? Well, they're not physically ill, and what's going to happen? You're gonna put this person in an expensive box with these expensive people who are going to show up to an even more expensive emergency department, and the physician's going to say, "Why in the heck is this person in my emergency department
Right.
in a trauma room,
Right.
taking up space? I can't help this
Because
person."
they're not injured. They're not
No,
ill in the fact of a
in the same
medical
way,
or condition, right? It's a mental
right?
health emergency. And if you've ever been to an emergency room, I've worked in one for many years. They're pretty chaotic. It's one of the worst places to go if you're
For
having a
sure.
psychiatric break or some sort of mental health crisis. So let me I want to go back to, it depends on who comes, right?
hmm
And maybe who should come
hmm
to that particular mental health call. Do we have a list of resources of here are all the things that are available? Here are all the places to take you. Here are all the beds you could go to. Here are all the mental health responders. And let's just write it down on a piece of paper so everybody knows who to call and where to go. Do you have that?
Well, see, that's where we really have to start, which is definitions and lists.
Okay.
Because we can't define, excuse me, we can't really define who should go
Okay.
and then what's going to happen and then where do they go. So if we go back to the example where we've got 3 flavors of responders at your house, and then they say, hey, we should call one of those mobile teams or a crisis someone, or isn't there someone that's supposed to come and help
Do we have a
us
list
with
of those
this,
teams?
right? In some jurisdictions, yes, we do. In others, there's some gaps.
Okay.
So then we're asking responders to wait
Gotcha.
and wait and wait. So we're keeping these responders out of service.
Which could be going to a even bigger emergency of a pediatric patient
That's completely appropriate for
Right.
those flavors of responders, right? So we're asking them to wait. And then and if they get tired of waiting, what are they going to do? They're going to throw them in a cop car or an ambulance.
and off to jail, which
Right.
is really not the right place for
No,
them.
we don't send
or the
people to jail
chaos of
when
an
they have a
ER.
broken leg, right?
Right.
Like, so, so we put this waiting piece in that's so frustrating. And then we say, okay,
For someone who's agitated, who doesn't want to wait.
wait. And so, plus then we have responders then who are agitated because their sergeants or their commanders are calling and be like, get
Right.
back, hurry up, churn the call, right?
Right.
So then we have, then we've got some sort of behavioral health crisis responder on scene or an officer on scene who's tasked with deciding, does this person need hospitalization or do they just need some sort of intensive intervention right now to help what's going on? Let's say for the sake of this argument, this person needs hospitalization. Okay, so depending on where my feet are, maybe I'm tracked to an emergency department. And then they're going to transfer the patient to a psychiatric hospital. Because remember, for the vast majority of our hospitals in our region, there is no psychiatric care that occurs in those facilities. There's no There's no psychiatrist on staff, or in the emergency department, there's no unit, there's no floor. Now, again, there are some resources in Austin, but we're much bigger than Austin.
Yeah, 11
right?
counties, right.
So, so then again, we have that patient sort of sitting there waiting to be transferred.
Yeah, so this, as we sit here and talk about this, I kind of think about CATRAC structure, and are we structured in a way that's best for all patients? And I think about um, conversations with our trauma work group, and they have very clear, specific trauma criteria, right? If you're shot in the chest, you're going to go to the level 1 or 2 trauma center. And if you're in a low speed motor vehicle accident, you might go to a level 4 trauma center. And so we have these very if this, then that standards. And it reminds me of when we were talking to our injury prevention and education committee chair. She was talking about BFAST, or the stroke scale. And so if you have these criteria with regards to stroke, you go to these stroke intervention centers, and those are defined, right? And we know who they are. And as I, continue to this conversation about mental health, it seems very chaotic. It seems very unstructured.
Mhm.
And it reminds me of 10 or 15 years ago, where the regional advisory councils had the same for trauma care, right? It was unstructured. It was not yet defined. And the purpose of the regional advisory councils, the RACs, and you can, listen to Because of a RAC podcast on a different story. But it was the reason the RAC was developed, is to look at the emergency healthcare system. In that case, it was trauma back then, but I think we should be looking at the emergency healthcare system in this particular cohort. And maybe the RACs, and I don't want to task us with more work, and I have 21 counterparts that might chase me down, but the RACs maybe should define, or be tasked, be funded even, to potentially define the workflow for mental health. What are the standards? Where are the treatment facilities? What are the beds? What are the basic expectations of care in that jurisdiction, in multi-county and multi-jurisdictional component? Would you agree with that?
Yes, because it impacts the entire system. We are impacting every level of care, whether that's taking up a bed in an inappropriate setting, or taking up ambulance time, or it, we are a thorn in the rest of the system's side, and we need to take care of our business, and that is coming up with a rational, logical flowchart system, algorithm, whatever we want to process.
We should be able to define our healthcare system. And in this particular case, it sounds like we really struggle. So that kind of, you were talking about the pre-hospital environment, and this, as we're talking, it kind of moves me towards the hospital side. It sounds like, the options are, in well-refined locales, you may access mental health in a more appropriate way, but generally you're going to jail or the ER, which is really sad to kind of say it that way. So that ER component kind of takes me into the hospital side. And I know, in talking with a lot of our hospital partners, mental health patients come into the emergency department. They get a psychiatric sitter, they get a 1-to-1. That nurse, that tech is not able to care for other patients. It's busy. If you've ever been to an ER, you sat and you waited and waited and waited to go back to see the doctor, which is the reason you went there, right? We know from, in this region, talking to our hospital partners, it's about a $6.9 million opportunity, where healthcare systems have identified about $6.9 million annually on expenses related to mental health patients that are simply waiting. And I say it simply, it's not simple, but they're simply waiting on transport to the appropriate mental health care facility, bed, whatever. And so they're sitting in the ER where they don't belong, where they're not getting the appropriate level of care. And that cost is a lot of money collectively. That seems like if we had $7 million, we could do it way different. So that I want to talk a little bit about that part, but I also want to talk about even if you're in the hospital, um, there aren't services necessarily available for your mental health needs. A lot of our acute care hospitals don't provide those services, and they're best provided at a mental health facility that's appropriate for that particular individual. Can you talk about that?
Yes, and also when you talk about, that person is just sitting and waiting, that person also has a sense of that.
Yes.
It's a terrible feeling to just be sitting there and knowing that you're not really sort of wanted. Like, there's a sense of like, you don't belong here. Why are you here? We can't help you.
And they don't mean it that
And
way,
they
but there's
don't mean
nowhere for
it
them to
that way,
go.
but it's just that it's hard for families and individuals to kind of be in that place, right? It's unfortunate. And so, yeah, so then we have a patient who's essentially sort of stuck for a while in the wrong setting. And if we have decided in this region that we are not going to provide psychiatric care in a what sort of a traditional medical hospital, um, then either we need to figure out how can I rapidly transfer this person to definitive care, or can I just go directly to the place that has that?
Right.
Right?
And that goes back to that list.
Right.
Like, if I had the list, maybe I knew where I could go, or even if I had to go get stitches or had to get some
Uh-huh.
hydration, now I know where I could go, and not just a list of the facilities, but do they have a bed right now? And
Mhm.
there's
And what flavor of
systems
bed?
we do that for cardiac care and stroke care. We do that all the time, and in many other ways. So I guess, kind of boil all that back down again. Um, is there a way to do it different?
I hope so. I believe so. I mean, I have worked most of my career to try and, shift this beast a bit. And I think, again, going back to some of the definitions, like what is medical clearance? So if we go to the patient either in the pre-hospital setting or in the hospital, either way, if I'm pre-hospital and I'm on a scene and I determine that this person meets criteria for inpatient care, and I have a list of 10 to 15 hospitals. Let's just say for the sake of ease that this person has insurance. Okay? So,
Many don't.
well, I mean, let's just because that takes us down a whole nother trail. So if I uh, start calling hospitals and I say, "Do you have a bed for 25-year-old male who is experiencing some psychosis and some suicidal ideation, um, and he had 2 beers today." 5 of the 10 hospitals are gonna tell me, "No, you need to transport him for medical clearance because there may be alcohol on board."
And hospital may not be what we're thinking medical hospital, right? The place with the big ER sign that says trauma. We're not talking about that kind of hospital a lot of times. We're talking about mental health facilities
So
or
so, yeah, if I'm calling, sunny Riverdale of the, Valley Hospital, and I call and say, "Here's my patient, will you accept them?" If I say they have diabetes, treated or untreated, or they have, they've had 2 beers or whatever, something that seems like something that says hospital, psychiatric hospital on the front of the building, that they could also tend to that. Oftentimes, they're gonna say, "No, you need to go ahead and transport to the emergency department,
even
to the
though
medical hospital."
the medical hospital, even though that condition, and for those of you just listening, I'm doing air quotes, right? But even though these conditions that we're talking about, diabetes, hypertension, how to drink, is commonplace in the
Sure,
population of I mean, there's so many of
absolutely.
us walking around who
Mhm,
take medicine for this, that, or the
mhm.
other, right? that seems so frustrating and frustrating for the patient to not be able to be accepted, right? That
Mhm.
again, now there's another reason I'm not wanted, right? I hate to say it that way. Um, but then it's also frustrating, I guess, for the provider trying to, yep, let me call again the next
Right.
one. And I just envision these crisis responders like yourself, and I'm in the hill country, XYZ, and every time I make a phone call, I get bump bump because the cell signal doesn't work out here, right?
Yes.
I
Mhm.
just how frustrating that is to
Uh-huh.
go on and on and on, particularly when I don't even have a list of places to start. In the tech-enabled world we are today, I can, Facebook, TikTok, share everything. I would think we would be able to share what beds are open and where they are
Mhm.
like we do in other
Mhm.
systems.
And some of that is because, again, if we're working with a freestanding facility, even though it says hospital on the front, they're gonna tell me, we don't really feel comfortable taking a patient that has X, Y, and Z symptoms. Why is that? Because they really don't have medical staffing in the building. Like, they have
Right.
direct care
But on the
services.
on the flip side of that, and this is the part that really challenges, I think, a lot of my emergency department counterparts. When you load up in the ambulance and you show up in the emergency room with the patient who needs some hydration or some stitches or whatnot and has mental health disease as well, they don't get to say, I'd be happy to give you some hydration, but I don't really feel comfortable with that psychotic component.
Mhm.
You can't come here. They can't do that. There's
Right,
rules against that.
right, right.
But the inverse seems to be not true, even if it's because I take insulin for my
Mhm,
diabetes or
mhm.
whatnot. And I don't want to oversimplify it, but it seems to be just a reoccurring pattern that this group of facilities just has to suck it up and take the patient
Right.
and then figure it out time and time and
Mhm.
time again, where other facilities may not have the same types of standards if we flip the diagnoses,
Yes.
right?
And then if we go then to the hospital setting, then we're again, there's this sludge around, "Okay, let's start calling.
Right.
Who has a
The
bed?"
same places
And
we just talked about trying to call.
yes, and then this hospital, psychiatric hospital, is going to give you a different answer about what labs they need, when they have a bed available, do they need a 12 lead or not? Do they,
Right.
and it's just, it's almost like rolling dice about
Wow.
who gets what when. Now, is that because the psychiatric hospital happens to have their psychiatrist present,
Yeah. Yeah.
and they want
So
this, that, yeah.
So the silver lining in that's the opportunity, right? So the opportunity in the region is to define what are those standards. If we're going to transfer a patient from the emergency department to a mental health facility, here are our standards in this region. This is we've we've put everybody in a room and we've collectively come to X, just like we did with trauma 10, 15 years
Mhm,
ago, right? It's a lot of work. It's painful work.
mhm,
It's, probably a lot of um, argument at times, right? A lot of passion
uh-huh,
probably in the room at times to kind of work through. But I think that is the opportunity in this region, probably across the state, is for I think RACs, right? It's our role to look at standards of care in our healthcare system, whether that be stroke,
mhm,
cardiac, mental health, it doesn't matter. Um, and so I think there's the opportunity for us is to let's start defining those standards. Let's start defining what those definitions are. You said earlier about medical clearance. What does that mean?
mhm.
Um, that sounds like a lot of work, and you have a big lift as your work group
Oh,
gets
I have
moving on
plenty of
this.
helpers.
Plenty. So it really seems today it's about the organization, the jurisdiction, the facility, their standards, their resources, their level of effort, and really not about the patient. And that's frustrating. And I hope we can get to a place where it's about the patient and not about do you meet my standards or have you filled out my paperwork or do we take this insurance or these labs have been done or these tests have been done first. Granted, every patient is unique, but
Mhm.
there seems to be a huge opportunity there.
Mhm.
What other things do you think the mental health work group should be working on? Or that seems like, a few years worth of work to
Yeah.
me.
And I think it's also, important for us to keep an eye on best practices, across the nation and bring them here and
Yeah.
say, this is what's going on in Washington or Colorado or Massachusetts and make sure that we're bringing those here. I think that's, just like we would with,
Yeah.
emergency medicine in any other
Yeah.
capacity. So I think that's going to take us a few years to.
Yeah, it does. And I mean, I'm just sitting here thinking about, how do we put more staff on this project to help you and facilitate that? And there's, really significant limitation on funding. Funding is typically directed to these particular objectives, and there's not any funding, at least in our organization, for these particular
Mhm.
mental health objectives. We're certainly going to do the best we can on it, but, you know, I, I have this kind of phrase of all things are solved with time and money. Sounds like we've been spending a couple decades on this, so the
Mhm.
time hasn't fixed it. So we shall see. But Annie, thank you so much for chairing the mental health work group.
Oh,
I
you're
really
welcome.
appreciate all of the vast experience that you bring to the mental health work group and to the region. And thank you for being here today, and we really appreciate it.
Well, and thank you for allowing CATRAC to step into this new zone of care. I really appreciate your leadership around being willing to say, this is an area we all know about it every day, but we're not really addressing it like we should. So thank you for allowing this piece of work to come into the CATRAC umbrella.
Yeah, you're welcome. We value all patients and believe that the center of our work should be about the patient and decreasing mortality, morbidity, and increasing patient outcomes. And our mental health patients are just one slice of all of our patient population. It may not be a popular topic, and I know there's a lot of feelings and passion and toes being stepped on, probably, but it's not about us. It's not about the responders. It's about the patient. And so I appreciate you and all the work, and thank you for all of you that are listening to this particular podcast. I know there's probably lots of topics and lots of opinions and lots of comments. We welcome all of them. The only way to make this better is to be candid, be transparent, and just trudge through it, just like we did trauma care 15, 20 years ago. And together we can do it. We have to just commit to doing it. So, but thank you all for joining. I'm Douglas Havron, the CEO and Executive Director here at CATRAC, and you've been listening to the CATRAC podcast. Thank you so much for being here. Take care. Be safe.